Hey everybody, Dr. Rob Silverman here. It's a pleasure. Proven Health Alternatives. I've got an exciting guest. This guy is going to amp you up without question. I'm happy that I was able to get him. He was there before me, and that never typically happens. We've got Sam Visnic on. Sam, how are you?
I'm doing great, Dr. Silverman. Thank you so much for having me on here, and I'm looking forward to chatting with you about some interesting topics here.
Without question. So we're going to talk a lot about approaches to dealing with chronic pain. And chronic pain is definitely at the forefront of everything that's going on in general. And then when you couple it with the COVID and the increase in chronic pain, I really want to delve into it. But as always, before we get in, let's get a little background. Why don't you tell people how you got here?
Well, I have a very interesting history. My work started in my journey, I'd say about 20 years ago. I was always the skinny kid, lifting weights, needed to spend his time in the gym. Let's put it that way. And, from early on, I remember these were the days where you go in and not much internet. You had to go in and sit in Barnes and Noble and Borders and read books. And there was the health aisle. And, it doesn't look like it did today. So, and a small assortment of books on bodybuilding. And I remember reading like Fred Hatfield and the more scientific stuff. I didn't like the loose stuff. I like to have a specific protocol on things. And that's kind of how I was. I really loved that stuff, and I followed it to a T and got great results. And once I graduated from high school, parents gave me the, it's time to sink or swim here. And I said, you know what, I can go be a personal trainer and teach people how to work out. That's pretty easy to do. So I got a job at the big box gyms, and very quickly you learn that when you start working with people, people have all sorts of aches and pains. And at the time, that really wasn't my intention. I just wanted people to, get muscle and lose body fat. But you had to learn how to work around the issues that people had. And this is also at the time where that kind of functional fitness boom was happening, where National Academy of Sports Medicine was out there teaching big box gyms, trainers how to look at posture and movement. Everybody's standing on Swiss balls. So this was like that whole time. And I got really good with dealing with and working around orthopedic issues with people. And no surprise, those of us now who know, I was getting people better. And then I became a sought after person. When anybody who had aches and pains and they were afraid to work with anybody in the fitness field, they'd come to see me and I would design them programs. And from there, I just kept getting more and more complicated cases and expanded my knowledge. I went after the industry experts, learned everything I could. I was devouring books on physical therapy and movement, and went to massage school because I had to get a license to put my hands on people. Right. And right away started taking trainings in neuromuscular therapy and basically any techniques that I could find, and started kind of piecing together my entire system and what now over 20 years has kind of accumulated into a multidisciplinary approach to dealing with these kind of chronic issues with people.
Yeah, well, that's a great starting point. You and I really parallel each other a lot because I have an injury. I have congenital torticollis. And I too was skinny and had to go in the gym and sweat to gain an inch on the bicep, if you will. Well, that guy who just looked at the weight grew. I hated him. But that's life. And so I really relate to that. And I got an injury because I was listening to all the guys on how to get big and move wrong and lift wrong. And I ended up going to chiropractor and put the wheels in motion, and the rest is history. Yep. And I too concur wholeheartedly that movement is a critical element to avoiding that chronic pain. Now, I'm a lot older than you. I'm in my 50s, so I have a lot of my colleagues coming in, not just chiropractic colleagues in life, and they're busted up. Yep. And I can tell you that I believe that there's another 50 left in me, and I don't want to walk around, banged up. So I really appreciate your epiphany. And it's interesting how so many people come on that what resonates with the people watching is the person actually went through it. You never, again, as I've said before, you never want to be a brain surgeon because you have brain surgery.
Yep.
You want to be because someone put their hands on you. So you're a massage therapist. You've done the training. You talked about your system. Do you want to go into a little bit more detail about your system, what it is, and how you decipher the different techniques that you're using now?
Well, things have evolved a lot. Like when we first started doing this work, I say we as a field, because I think the whole field has gone through this evolution to some degree where everything was very structural biomechanical. We looked at posture, we looked at everybody had anterior pelvic tilt and all this kind of stuff. So very early on, as I was doing these assessments, a lot of my colleagues, and this is something that's common in the industry, make a lot of assumptions. And, they'll look around and, look at someone's posture, assess them for 5 seconds and determine what they've got going on with them. I was actually doing all of the tests. Everybody would come in and tell me, hey, I have a tight psoas. This is what I've been told. I would put them on the table. I'd test everything. And I started to become kind of skeptical of what I was finding and what people were saying. And that led me into, hey, you know what? I actually was finding more often than not, I was seeing tons of negative psoas, Thomas tests. I wasn't seeing what everybody was saying. So I had to dig a little bit deeper and saying, something else is wrong here. This person has a loose psoas, it's weak, and so forth. So when you start kind of diving into, and you can't help but kind of get into the neurology of what's going on with people's bodies, and how people were experiencing things like having chronic pain in the hips and the low back and so forth, but yet they weren't showing any of these muscle imbalances and these obvious structural issues. And so that leads you kind of deeper into the rabbit hole. Early on, again, it was a lot of, dancing around to different disciplines. So once I kind of looked at, you can't fix everything with exercises. Exercise was good with people. But then I was doing manual therapy, and I went through a phase where I did just almost exclusively neuromuscular work, myofascial release techniques. And I was getting similar results, but I was getting hung up at different points. So then you start to kind of piece these things together and figure out somehow these things have to interact with each other. You can't get things better just with exercise sometimes. Sometimes it's not just massage. And then, as you learn more, you start looking at kind of other models that talk about, like I was seeing nutritionists who are colleagues of mine who were working with people with pain, and they were getting them out of pain, and they never did any exercise work, and they never did any manual therapy. So then you have to go over here and go, what are you doing that's getting people out of pain? And now you start to look at, hey, these people have inflammation, they have sensitive gut sensitivities, they have digestive issues, and these things were ramping up their inflammation. And then we start saying, hey, you know what's happening here is it's overstimulating this person's sympathetic nervous system. And then we say, well, what happens when the sympathetic nervous system gets overstimulated over here in the structural mechanical realm? We see predictable patterns of muscle tension, the psoas, the upper trapezius, et cetera. And then you start looking at all of these things. You're like, all right, I got this client who's coming in presenting with low back pain, or they think they have an SI joint problem, and they drink a gallon of coffee a day. They don't sleep at night. They have rampant inflammation because their diet is very poor. And here I am just trying to massage or exercise my way through this person's problem. This doesn't make sense. So as you start to kind of learn around and dig into more of what I would call, I wouldn't call myself a researcher. I call myself an aggregator of information, because I'm not diving in reading every bit of research. What I'm doing is going to a lot of my colleagues who are experts in this and saying, hey, you've read a lot of this stuff. What are you finding? And kind of looking at these people who are accumulating things. And I'd say the one thing that has changed my perspective the most in the last 10 years was I would say the discovery, which was really a confirmation of what I was finding in pain neuroscience education. Because pain neuroscience education was now starting to accumulate a lot of my thoughts on things and kind of putting them together and say, hey, the research actually proves this. We know this is true. And those of you out there who are not familiar with pain neuroscience education, it's really the understanding that pain and the study of pain is almost a completely different field than the structural mechanics and so forth. But it helps us square up some of these things that we find that don't make sense. How can people have a lot of pain when they have no tissue damage or injury? And then we see in our world, we almost always assume that those of us who come from a structural biomechanical approach, that pain always has to have this structural mechanical kind of origin, or has to have a tissue damage origin. And it's not true at all. So it kind of blew the lid off of that whole thing for me.
Wow. Great stuff. I'm getting buzzed right here from my chiropractic brethren right now on my phone. So if you have a question, everybody do me a favor. I'm going to turn the comments section on. So feel free. We'll answer all questions. They'll pop up for you. But I got a lot, as I've always said, to unpack. Let's go back to the psoas. Psoas, great thing. Everybody who has lower back pain should have their practitioner take a look at their psoas. It goes from T12 to L5, doesn't touch the L5 disc. It's a critical muscle in that it touches the spine, the ilium, the sacrum, and the femur at the lesser trochanter. More so than that, you said something interesting, tight and weak.
Yeah.
So everybody says my hip flexor is tight, Dr. Rob. Do you want to expound on that just a little bit?
Well, and this depends on where you come from, because I know that, of course, everybody has a different vantage point on when we look at things like the psoas. But as we all know in this field anyway, I'm speaking, assuming that a lot of people on here are colleagues, that we know that no muscle operates by itself. That's not the way that it works. So we see that we have things sometimes that are primary issues. We can strain or we can pull a muscle. A lot of times we see that these things are compensatory activities. I take on a lot of the view of, I think the Postural Restoration Institute has really helped me with a good understanding of what happens with the psoas, especially when we're looking at the difference between what the left psoas is doing and the right psoas is doing as a compensator for that excess, what we call left external rotation of the left hip, because the pelvis is rotating. So when I look at these scenarios and I say, well, in this position, what's happening is the psoas is actually being forced to do much more work because it's being a structural compensator. But in fact, a lot of times the psoas isn't very strong, especially in deconditioned people. So when you test that muscle, it's going to present one of two ways. Either number one, it's just going to feel flimsy and you're going to have a negative 15-degree drop on the Thomas test, or you're going to have somebody where that muscle is guarding and it has a hard time letting go because essentially it's just being overworked and strained. So when we look at these things, it's hard to just judge if something is just, tight or weak. We have to say, does this muscle have adequate capacity to do its job? And why is it doing this? If we do things like mobilize other tissues or fire other things up with exercises and that psoas lets go, or it seems to kind of go back to its normal tone and position, then we have to look at it like that. And to me, these are easy tricks that I think most of us in the field have amassed a lot of different techniques to be able to restore kind of like a functional balance to these things. But I'm still trying to go back up and go a little bit more meta to why this is happening to begin with. Why are we seeing this situation, and how do we get it to actually, which is even the bigger thing, it's getting it to stick. It's very easy to get a rapid fix, but this work doesn't stick because of the larger issues that we're seeing with the nervous system and with that person's biopsychosocial situation and why the nervous system is doing what it's doing.
That's fantastic. And I agree with you, because a lot of people think that the psoas is always tight, but it may be shortened and weakened.
Yeah.
And when the psoas is aberrant, it shuts off its antagonist muscle, which is the gluteus maximus, strongest muscle in the body, not per square inch, causing a whole lower back cascade. I mean, we can go in we can get a little too granular with the quadratus laborum. We're going to hold off on that. We'll talk about that when we're off.
Yeah.
But you also said something was great. It's not exercise, it's nutrition.
Yep.
And the really thing that I want to circle back to was the sympathetic nervous system. I think that's fabulous. People don't realize that when they get too sympathetic, especially now. I mean, sympathetic is fight or flight. Parasympathetic is the equalizer, which is, wine and dine. Everybody's a little sympathetic. We have this thing called COVID-19. So interesting, when the sympathetics are up, you have more muscle tone and you're tighter.
Yes.
And I thought that was a great alluding to then following up with pain neuroscience education. Chronic pain, neuroscience, got to be a direct correlation. So I'm serving up the softball for you right now.
Okay, so we look at these two different divisions of the nervous system. Of course, we should have a relative balance, and that's depending upon someone's genetics for the most part, but also functionally, like how they live their lives. And we lose the amplitude or the strength in these systems over time. This used to be described in this field, and in the functional medicine field is still talked about in terms of adrenal fatigue. But for the most part, what we're talking about is an individual's ability to cope with stress. And the way that we live right now, we are not meant to deal with these kind of low-term or moderate chronic stressors for long periods of time. So what happens is the sympathetic nervous system loses its ability to peak. We don't get the swing, the diurnal cycle up and down in the nervous system, and we do lose both of them. We lose the ability to get that sympathetic arousal or that peak, and we also lose that ability to go into that rest and relaxation to the amplitude that we had when we were young. So we get into these situations where that adrenal fatigue storyline, which is we kind of go to that level where we're tired and wired, and then we go to the phase where we're tired and we're exhausted, and we can't get that nervous system up. When we see people in practice, they're going to have presentations physically that are manifestations of that as well. So we're so used to listening to what they do in their health, and they say, I drink caffeine, I don't get amped, I'm tired all day, I can't sleep well at night, all these things that don't seem to kind of square up. But we also see that physically, but we don't seem to look at that as well. So you see a psoas, and you might consider to yourself, is this psoas tired and wired, or is this psoas tired and exhausted, and it can't do its job adequately either? So using that as a metaphor and seeing kind of like as a relationship to what's going on with that person based on the symptoms that they have everywhere else in their life. I mean, how many times do you see people with hypermobility who also have that common likelihood? They have increased anxiety problems. It appears to be parasympathetic dominant. They have asthma. They have allergies. We see this whole constellation of symptoms that's going on with that person. And then the first thing that the practitioner wants to do with them is to assign stretching and mobility drills. And it just makes the problem worse because that person needs to get a little bit more sympathetic upswing. And obviously everybody needs to recover from stress, but that person's body needs more boundaries and more rules in there to be able to kind of keep it stable. So I'm kind of going off on a tangent, but the key is that we actually have to look at each individual and figure out where they are on the spectrum of everybody being in this over hyper state of chronic stress and what stage they might be in so that we can assign the appropriate therapy to that. And when it comes to pain neuroscience and teaching these different things is classifying the different kinds of pain that people are experiencing. You know, we're used to in this field dealing with the nociceptive kind of idea where we're just everything is muscle imbalances, joint imbalances driving that nociception up. But the issue with that is that there's also different types of pain that we have to look at. In particular, the thing that a lot of practitioners are not paying too much attention to with chronic stress syndromes is the categorization of nociplastic pain, which is central sensitization. These are people where their nervous systems are just constantly in a hyper state of vigilance, and they are misinterpreting the information that's coming in from their bodies. And when we apply a stimuli or a stress to the outside with our therapeutic inputs, we're going to get a vast variety of different responses from this person. And now then what we know, it appears in the pain neuroscience, is that to some degree, pain cannot be easily classified as being, nociceptive or this neurogenic or nociplastic. It's always some degree a combination of all of those elements. And this, again, I think has a lot to do with us paying attention to how much stress load that person is under and how much sympathetic load they have and figuring out which way that's pushing them. So we can, again, try to figure out the ideal combination of kind of therapeutics to work with that individual.
Absolutely. So I can say this. Everybody comes in and says, are there any stretches I could do? And it's the first thing they want to do. So I think I'm extrapolating from what you said. There's stability, mobility, and then flexibility. And the stability comes from the idea of proprioception. And, because I understand exactly what you mean about central pain sensitization.
Yep.
So with that being said, there was a great article, I think it was 2016 in British Sports Journal, which spoke about the idea of rehab, where it had exactly what you're saying. You had to have the proprioception, the rehab, the balance in space between your nervous and your muscular system, but you also had to have strength training. Because if you did one without the other, you were lost. It wasn't true. It was not neuroplastic retraining like you talked about, neuroplasticity, the ability for your brain to, it's plastic in form and have new nerves. This is great stuff. Now, you have a program that's really interesting. It's called Release Muscle Therapy Program. It's very unique from hands-on therapy approaches. You've mentioned a lot of interesting information. What is it that you do, and how is that different, and how does it pertain to chronic pain?
Well, we have a lot of these. And I think, again, the beautiful part about our therapeutic industry is that people are figuring out so many different things that work. And, we're always trying to create separation between these things and why this works and that doesn't work and so forth. When really we should be kind of looking at it from a meta position where we say, what's common amongst all of these things that seem to work? And really what we're doing for the most part is helping that person's nervous system feel safe. So chronic pain is, and pain itself is essentially an alarm system. We don't have pain fibers in our body. What we have is nerves and receptors that send information to the brain. The brain has to make the determination of are we feeling a threat and to what degree are we feeling threat to turn the pain alarm on. So virtually anything that reduces that alarm and changes the brain's perception of what's going on in the body is going to be helpful. So you could take any therapy, and we all know that they work under some circumstances with different people. Everything works. The question is, how do you kind of combine all of these elements for a maximum effect? And that's kind of like what I've done within my scope of practice anyway, of what I can do, is that when people come in, first of all, I'm usually not the person that people see first. I make sure that people go to their doctor, they go to physical therapy, they've kind of done all the general stuff. And if they're still left with chronic pain afterward, then kind of like I can jump in and do what I do. So I have things within a boundary set that I need to have in order to get the best results with people. So when they come in, I know that they've kind of hit the basics. I do an interview with them. I do a lot of questioning because what I'm looking for with the kind of work that I do is to figure out what kind of beliefs they have, what kind of understandings they have about pain. And these are all key factors because that's telling me how they're perceiving what is happening to them. The chronic pain cycle is quite vicious in that people are constantly chasing after different diagnoses, when they go after and they get different diagnoses, they get different treatments, those treatment times oftentimes fail, and they have if they've come to me at this point. And that's further creating and exacerbating the chronic stress cycle because they have no idea what's going on with them. And that is increasing the alarm. It's increasing the perception of threat, and it's oftentimes contributing to the chronic pain cycle. So I have to break that. So the first thing we do first and foremost after gathering that information is do pain education. I teach every client at least 15 to 20 minutes of pain education, and I tailor it toward what their misunderstandings or the gaps are in their level of knowledge. I'd have to say now, in doing pain neuroscience education for 10 years, I've never had a single client come in now that could define what pain is. They don't even know what it is. They don't know that it's an alarm system. They don't know that they don't have pain fibers in their system. There's all sorts of misunderstandings. So when I'm helping them understand that what it's all about is reducing threat and what we're actually doing when we do this work and moving away from, I would say, excessivism when it comes to structural biomechanics, because everybody believes their issue is 100% structural and that none of the other lifestyle factors really interact with this. They really don't get that. So I explain it to them, and then I follow up with education. Then on the first visit, I am going to do an evaluation from them structurally, but I'm looking at different things. I'm looking at patterns. I want to know how they use their body, which way they tend to position themselves. So I do identify that. Usually on the first visit, I will give them a reciprocal program. So what I will do is I'll take all of the imbalances that I find in terms of their body style and positioning, and I will give them a complete antagonistic program for that to see how they respond to it. Because the assumption that I have is that the way that they're neurologically positioning themselves, either they're in that position because they're running away from the opposite position, or what they're doing is that position is staying put because they are incapable of actually using the opposite side. So what we'll do is we'll tinker with these things and then see what kind of response we get when I shift somebody out of that position. And then the work is really just ongoing, trying to get that position to become more competent. So there's a lot of pieces to this too that I'm not describing, but it's not purely what I would call a structural mechanical kind of approach. What we're doing is also kind of with the neuroscience principles. Number one, pain education is very important in my approach. The more people understand about pain, the less threatened they feel by it, and the less threatened they feel by what we're doing. Number two, we go into the lifestyle factors. And one of the things that the research is very clear on is that the quality of sleep dramatically impacts your ability to basically tolerate pain and to actually recover. So I teach patients things like, for example, you keep a journal. And if you notice that you're having flare-ups, and the first thing that people oftentimes do in our world is to go, those exercises made me hurt. And I say, are you sure about that? When I did them with you in the office, it was fine. The next day you were fine. Spontaneously on day 3 or 4, the exercises now make you hurt. What happened the last couple of nights? And they go, well, I had a couple of bad nights of sleep. Okay, well, now poor sleep quality is going to increase sensitization of the nervous system, right? You're going to be sensitive in a lot more ways, and those of us who are parents know you have a couple of bad nights of sleep, loud noises are more stressful, and, minor irritations from your kids are more stressful, right? But I try to teach them that same thing. The third thing in there is making sure that we do adequate movement, right? And we need to do non-threatening movement activity. So, but I want to speed forward because I want to get these key points in to understand why I take that approach. As number 4 is the goal setting. Now, a lot of times, our clients predominantly come in because their outcome is they say, I want to have less pain. But we know that this is not a good outcome because we can interrupt pain quite quickly by altering neurology and reducing perception of threat, especially with chronic pain. But we need to get the mind and the brain to be oriented toward improvement and functional outcomes. That's what makes the difference. So when people come in, they're oftentimes plagued by what they can't do. I cannot do this exercise. I cannot go golf. I cannot do all of these things. So they feel limited. And what I'm trying to do is to say, hey, if I give you this antagonistic program, so I take your muscle imbalances or whatever, and I give you the opposite things, and they go, hey, I could do all of this without pain. It starts to kind of open up that window and saying, wow, really, there is a lot of stuff that I can do that does not make me hurt. And that's kind of like how we start this process to showing people what they're actually capable of doing and improving their ability to be functional by using kind of the opposite pattern of what they do. So our brain is constantly on moving toward what we want them to be able to do and increasing their functionality rather than fixating on the area where the pain is and how many problems they have with that area, because that increases the sensitivity to that situation and of course increases pain, because the nerve receptors are now upregulating where they pay more attention to that limb, and it always hurts and it exacerbates the pain cycle. So a lot of these things is tough always to put into practice sometimes, because people don't really understand this, because they want you to treat the area where the pain is. But that is not always the effective way to go. And especially when people have seen 10 practitioners previously have done that exact same thing and it's not working, I'm for certain not going to be that person that does that again.
Without question. Again, tremendous amount of information, which is great in a very tangible method. Just to speak to what you said about pain, and as a chiro, people come in and go, it hurts here, it hurts here. Yonder once said, "He who treats the side of pain is lost."
Yes.
And the body's all interconnected. And that is what you're saying. We're put together by signals, whether it be chemical, neurological signals, and that's great. I love the idea of posture. My God, his name escaped. Sheridan once said that posture is the shadow of movement, but posture is really neurologically based also. Sleep, what a great concept. Get a better night's sleep. People recover better from pain or chronic pain. Now, to speak to the idea of chronic pain, one of the things that I really want to piggyback on what you said about chronic pain being in the brain, it was explained to me once that I was asked, did you ever step on a stick or a branch? Yeah. Did it hurt? Sure. Have you done it again? Yeah, multiple times, unfortunately. So if this is the 5th time you've done it, does it hurt more or less? More. Do you know why? No, because I don't see any tissue damage. Yeah, but your brain remembers it. You can, and it's telling you, stop being clumsy and damaging that tissue or causing any discomfort. So that chronic pain is in that chip called your brain, which is only 3 pounds.
Yes.
60% of fat. Fabulous. So what you're saying is you do all this work, but you're releasing muscles and working on the body, but you're working within the central nervous system. So the brain remembers the new position and the proper way to move. With that being said, obviously you're a leader, you're an elite leader in the field. What are you working on now based on where you see things in the field going?
Well, and to go off of what you just said there, I no longer think about muscle imbalances and these things. We have to generally talk about this stuff for the general public, because this topic is just way too over the head for most people. But we're really talking about the nervous system. Yeah, all these things. We have muscles, we have joints and so forth, but we know that a lot of the work that we're doing is neurophysiological in basis. It's tough to prove with some of the research, and we see that a lot of people are debating currently whether or not you can reform fascia and so forth. And I don't get myself too involved in those discussions, but we know that we can rapidly change things with our techniques. And the only thing that really explains that is our ability to affect the nervous system. So I'm looking for greater and faster ways to affect the nervous system and to tie into that element of chronic pain. And chronic pain becomes patterned, it becomes behavioral. The biopsychosocial elements, everything that affects and surrounds somebody when they have chronic pain, how the other people treat them that are conditioned to treat them in a certain way. The husband who develops a chronic lower back problem, he gets up, he's about to go take out the trash, and the wife goes, no, I'll do it because you have a bad back. Think about how that impacts that situation. It reminds that nervous system that it is incapable of doing things. And we don't, as practitioners, a lot of times don't consider this, that when that patient leaves the office, how does their world change, and how are they impacted by everything that is now subconscious that perpetuates that chronic pain cycle? So what we need to be able to do is to get in there and alter that nervous system's perception of things. And a lot of ways is we have to kind of enter into a little bit of the psychology realm, as we know that a good chunk of a lot of this behavior now is unconscious. For the most part, people just kind of move through their lives and they delete most information, especially how all of these factors in their lives are impacting them. And a lot of our work is about bringing that non-conscious stuff into their conscious awareness. We even do this through movement. Hey, did you notice that when you bend that way, you round your back versus hold an arch? A lot of it is teaching people that they're completely things that they're unaware of and bringing it into their awareness. So when we look at chronic pain, a lot of the research into that direction is about pain education and so forth. The problem with this still is it's in its infancy. And to me, I look at it as very similarly to the psychology field or the therapy field, is that we know that just sitting in an office and just telling people, therapists, what's wrong with them or why they have these problems or because they had this issue when they were a child or whatever, that is a left brain strategy. And this conscious understanding of a situation doesn't necessarily change anything. For some people, it does. Once they bring awareness to a situation, their nervous system can just make the changes and they start behaving differently. But a lot of people, that's not the case. The knowledge and the education is not enough. Behavioral change is far more complicated than that. So looking into personal development strategies, I've been a long-term fan of, but have not practiced in a long time, like in the way, because of the kind of work that I do, and I'm just kept busy, and looking at things like clinical hypnotherapy has been a big interest of mine for a long time. And hypnosis in particular is, despite its stigma, that people have with it, has kind of stayed in the shadows of this work for a long time. Hypnotherapists have been helping people with chronic pain for 30, 40 years now. This stretches back. It has a very long history of being successful. Now we're seeing a lot more research that's coming out. In particular, Mark Jensen, University of Washington, has done boatloads of research on clinical hypnotherapy. It is highly effective. So now we're in a field now where we're talking about meditation and mindfulness and these sorts of techniques that, in my opinion, are a bit looser. And hypnotherapy is a lot more, rules to it and protocols. And it's been, like I said, it's been a challenge to kind of get that off the ground and getting a lot more people to talk about this. But it's really where we're going when we talk about pain neuroscience, which is educating on people on things consciously. But now we need something to kind of work on the subconscious elements of behavior and changing people's meanings and beliefs that are associated to what it is that they're going through, and to teach them internal techniques to be able to change their responses to stimuli, right? So this is an element that has been missing. And what I've been working on now is integrating a lot more. And it's, as always, it's a little bit of a challenge kind of from a practice standpoint. Implementing this is changing lanes constantly with people and saying, here, we're going to look at mechanics, and then I'm teaching you this pain neuroscience stuff. It's already hard enough for people to understand how those two things relate. And then going over here and talking about nutrition and inflammation, but then also going over here to hypnotherapy. So this is always the challenge that it seems like anybody that does multidisciplinary practices has. But I'm definitely moving into that direction because I see that there's just so much potential to be able to help people. And really, for me, over time, this comes down to speed. The better we get at this work, the faster we should get at this work, the faster we get resolution. And that's really what I'm after, is to figure out how I can make all these components work to get even faster results.
Excellent. And everything's based on patient results, patient outcomes. I hear that reverberating off the walls when I speak to you. You mentioned fascia, the saran wrap of the body. Fascia, because it attaches to the skin, is now the largest organ in the body, and it's an intracellular signaler. We could have a whole webinar, discussion, podcast just on fascia, and we'd have to do it in a couple of parts. It's great. A lot of people have been reaching out to me, and that's why I'm looking down over here at my phone. They just don't want to do it on live. So what they want to know is, number one, where can they get in touch with you? Number two, can you give them a little background? You got a great book. You sent it to me. It was an ebook. I was able to go through it. It was outstanding. So could you tell them about the book and how to get in touch with you?
Well, the book was really what I would say was like a compendium, or just what I wanted to do was to just keep running track of, I didn't want to keep telling people about things and then not having to have the information to back it up. So I say I'm a very evidence-based practitioner. Of course, I come from an alternative field, so that's kind of hard to do sometimes. But I said, what is the literature? What is the research found? I'd find things like, for example, everybody argues, hey, you shouldn't be drinking caffeine or coffee because it fatigues your adrenals and it makes your pain worse. I'm like, what does the research say about this? And actually, the research says the opposite, that caffeine is a great analgesic. It works fantastic and it lowers pain. And I'm like, okay, well, there's something still wrong with this, because we do know that when people drink too much caffeine, it definitely makes them worse. So, but we start to see some of the parallels when you look at this and say, well, yeah, it's an analgesic. But the problem is with it is, if we jump over here and say, what's the number one thing that impacts your ability to cope with pain? It's sleep. Okay, well, what's the number one thing that tends to get in the way of sleep? Too much caffeine. So is caffeine itself really the problem, or is caffeine screwing with sleep, and sleep is making the pain worse? So we have to kind of like dive in a little bit into that stuff. And that's what I wanted to do with the book. And I did sections of it. And I said, well, this is what the research actually says on posture. This is what, and I do have my own information in there as well, my contribution, because I do disagree sometimes because of how the information is put together. So I added that all in there, and you can read that as my input and my intake based upon what the research shows. And how to square some of that stuff up. And I talk about hypnotherapy in there, what the research says. I talk about pain neuroscience education. What does the research say about orthotics? There's a lot of stuff in there. And again, that doesn't mean a knock that these things don't work for certain people under certain circumstances, because they certainly do. And us practitioners, who have experiences with this clearly know it works. But again, we have to square that up with all of the other elements. You know what I mean? Is it the exact prescription of the orthotic that matters, or is it that we're throwing a wrench in the wheel and we're altering sensory perception, and that's what's making the difference? Or, and I just want to keep that as a kind of a running live document that I can continue updating it based upon my findings and, what I'm seeing out there. And that's kind of what I wanted to offer. And I wanted to give it away for free so that people can have access to it. And I give it on my website. My website is releasemuscletherapy.com. If you kind of scroll down to the bottom of the page there, you'll see that I have a free membership area, and I put all my free content in there. People can have access to it, read those ebooks and so forth. I got a lot of quick fix ideas in there for people too. Some of my favorite things when they do have a stiff back and so forth. But I also offer some of those other things as well.
That's great. And again, they can get in touch with you through your website. You want to give a phone number?
Sure. Although you're going to get my answering, my gatekeeper on there, which is 424-442-0663. Of course, I'm also very active on now continuing on YouTube. Sam Visnic. You could just search my name on that. And Instagram handle is Release Muscle Therapy as well.
It's fabulous. It's been great. I wish we had more time. We, without question, have to do it again.
Absolutely.
Without question. It was enlightening, and it was clear there was some erudition for those who were watching. I appreciate your time. Thanks so much. Look him up. That was a great job, Sam Visnic.
Thank you so much for having me, and hope that was helpful for everybody out there.
Oh, without question. It was stellar. See you soon. Thanks.